Welcome to our video on large vessel vasculitis. Before I go any further, I want to mention that this image was contributed by Amboss. So thanks to our partnership with Amboss, I can highlight several important features of large vessel vasculitis. Now, different types of vasculitides can be classified based on vessel size. This slide serves as a visual aid to help us understand and classify the different types of vasculitis. Vasculitis involving large vessels typically involve the aorta and its major branches. Takayasu and giant cell arteritis are the most common diseases under this group. Medium vessel vasculitis mainly affects medium arteries. Polyarteritis nodosa and Kawasaki disease are the most common diseases seen under this group, and we will discuss those conditions in our medium vessel vasculitis lecture. And then small vessel arteritis involves small arteries, capillaries, and sometimes venules. The most notable examples are microscopic polyangiitis, granulomatosis with polyangiitis, Hinoch-Schönlein purpura, HSP, and eosinophilic granulomatosis with polyangiitis, cryoglobulonemic vasculitis, and cutaneous leukocytoclastic vasculitis. And those will all be discussed in our small vessel vasculitis lecture. In this lecture, we will focus on large vessel vasculitides, namely temporal or giant cell arteritis and Takayasu arteritis. Let's start by discussing the definition, pathophys, risk factors, as well as the clinical features, diagnosis, and management for temporal arteritis. Temporal or giant cell arteritis falls under the large vessel vasculitis, as we mentioned previously. And this is characterized by inflammation of large vessels, mainly involving the temporal arteries, but it can also involve the aorta and the carotids. Let's talk about the pathophysiology. While the initial inciting event is typically unclear, injury of the endothelial lining of large vessels induces cell-mediated immune response, resulting in cytokine release. This attracts more inflammatory cells, including monocytes. These monocytes, under the influence of cytokines, turn into giant cells, and granulomatous inflammation ensues, hence the name giant cell arteritis. Now, these giant cells secrete various growth factors and cytokines, including VEGF and PDGF. And these contribute to intimal proliferation, resulting in obliteration of the arterial lumen and tissue ischemia. So think of that intimal layer of the artery and just closing in. So naturally, ischemia would ensue. Risk factors include age greater than 50 years old and female sex. Notably, temporal arteritis is twice as common in women as men. So if you encounter a question about a female over the age of 50 who complains of a severe headache, especially over her temples, at least consider giant cell arteritis. Also know that this condition is commonly seen in people of Northern European descent. This slide describes the clinical features of the disease. 40% of patients have polymyalgia rheumatica, which is also an inflammatory disease that causes pain and stiffness, typically in the shoulders and hips. And it's a very strong association, so lock that in. Now, because temporal arteritis affects the temporal arteries, severe headache and tender temporal arteries, as well as jaw claudication, pain with chewing, can also be present. Patients can present with constitutional symptoms as well, such as a low-grade fever, night sweats, weight loss, and malaise, and that's all due to the chronic inflammation. And the ophthalmic artery is also commonly involved, leading to visual impairment, typically manifesting as a sudden, transient loss of vision, but it can actually progress to permanent vision loss. Hence, the importance of timely diagnosis and treatment. Thanks to Amboss, I can highlight several of these important features of temporal arteritis. So take a look at this image. On physical exam, as mentioned before, it's possible to see the prominence of superficial temporal arteries. They can even be palpable. As we mentioned previously, polymyalgia rheumatica is associated with this temporal arteritis. And this is an inflammatory disorder that causes stiffness or tenderness in proximal muscles, commonly in the shoulders and hips, as shown by this image. Also know that pain is worse in the morning and with activity. Now let's talk about how temporal arteritis is diagnosed. An elevated ESR and C-reactive protein are typically seen in laboratory findings, as they are important markers of inflammation. And a duplex ultrasound can also be used to assess potential stenosis and occlusions, as well as any flow abnormalities within the vessels. And findings can reveal hypoechogenic halos, often called the halo sign, and you'd see turbulent flow within the affected vessels. Now, these findings are due to the vessel wall edema and that thickening, secondary to the vasculitis. However, biopsy of the temporal artery is more sensitive. Now, it's important to note that some areas of the artery are not going through the inflammatory process. It's not this continuous problem throughout the entire vessel. So, on biopsy, multiple sections of the artery need to be examined. And on the biopsy, you might find thrombosis, necrosis, lymphocytes, plasma cells, and giant cells. But if there's a high suspicion of giant cell arteritis, medical treatment actually shouldn't be delayed for any reason. As we mentioned before, you don't want them to experience permanent vision loss. Here's an image from a biopsy of a patient with temporal arteritis. Note the multinucleated giant cells and intense intimal fibrosis. Again, you just think of that intimal layer just encroaching on the inside of that lumen. Immediate treatment is required once a patient presents with signs and symptoms of temporal arteritis. In fact, you give high-dose steroids even before the biopsy is performed, especially if the clinical suspicion raises your concern for temporal arteritis high enough. Now, admission is necessary if there's any visual loss present, and in that case, you would make sure you're giving IV steroids, but eventually, you'll transition the patient to oral glucocorticoids, and then you, of course, taper them slowly. Now, if vision loss is not present, then treatment can be limited to oral glucocorticoids. A 63-year-old female presents with a severe unilateral headache. Initial labs show elevated ESR and CRP. Physical exam reveals temporal arteries tender to palpation. What is the next best step for confirming the diagnosis? So the answer here would be a temporal artery biopsy. Now recall that the biopsy is more sensitive than labs. However, if there's a high suspicion of giant cell arteritis, you don't want to delay treatment. So this question was specifically asking about confirming the diagnosis and what's the best step there, not really what's the exact thing you're going to do in real life. But if you were thinking about giving them high-dose steroids, then you were still thinking about this correctly. Here's our overview slide again, and now we're going to be discussing Takayasu arteritis. Once again, we're going to go through this sequence of features, starting with the definition. For Takayasu arteritis, we'll discuss definition and pathophysiology together. This form of vasculitis presents with granulomatous inflammation of large vessels, as we mentioned before, and this is mainly affecting the aortic arch and its major branches. The chronic inflammation results in fibrosis, and that causes narrowing of the vessels, and of course, that narrowing would compromise the blood flow, and it can actually lead to pulselessness and ischemia. Takayasu arteritis is similar to temporal arteritis. However, this disease is actually seen more often in younger people, so patients younger than 45 years. And this condition is also common in Asian women. Constitutional symptoms such as fever, night sweats, malaise, arthralgias, and fatigue are all common. And these symptoms are likely related to that chronic inflammation that they're experiencing. And patients often present with an absent pulse in the carotid artery, or even the radial arteries or the ulnar arteries. And this is why the disease is often called the pulseless disease. And so naturally, it would make sense that there would be hypoperfusion, especially of those limbs, and lead to limb ischemia. Similarly, hypoperfusion of the brain can result in a stroke, and hyperperfusion of the myocardium can result in angina pectoris and myocardial infarction. And as we mentioned on the previous slides, hypoperfusion and ischemia of tissues is due to that fibrosis and narrowing of the vessel lumen. Now, as the disease progresses, structural changes in the major vessels can result in aortic aneurysm and aortic regurgitation. In addition, involvement of retinal arteries causes hemorrhages and vision loss, while renal involvement can cause renal artery stenosis. Now, renal artery stenosis typically leads to secondary hypertension due to excessive activation of the renin-angiotensin-aldosterone system. Lastly, skin manifestations are often seen in the lower extremities, but only in a minority of cases. And when you do see them, it's most likely to be erythema nodosum or urticaria. Diagnosis of Takayasu arteritis is clinical, and findings that are particularly suggestive of the diagnosis include age of onset less than 40, claudication of extremities, and this presents with fatigue and muscle discomfort with exertion, which makes sense. If your muscles aren't getting enough oxygen, then you're going to get tired. It's going to hurt when you move it, and you'll just be uncomfortable. And decreased pulses at one or both brachial arteries. And clinically, you can see decreased pulses at one or both brachial arteries. And systolic blood pressure difference greater than 10 millimeters of mercury between both arms can also be indicative. That makes sense. If you have one arm that's not getting as much of the pressure or the blood flow, then you'd expect a pressure difference. Also, bruits over the subclavian arteries or the aorta can also be heard clinically. On laboratory investigations, elevated ESR and C-reactive protein are typically found. It makes sense because these are markers of inflammation. Now, the narrowing of the arteries can actually be visualized using an arteriogram. And findings include narrowing of the lumen of the aorta and its branches. And then if you biopsy it, that will reveal granulomas. And you'll see those in the aortic arch and its aortic branches, as mentioned before. And the biopsy will also reveal fibrosis of the actual vessel wall. This slide illustrates an angiogram of a patient with Takayasu arteritis. This here represents the descending aorta. Notice the areas of stenosis. Stenotic areas can also be seen in the major branches of the aorta. In this case, we can see that in the left common carotid artery, as well as the left subclavian artery. Treatment of the disease begins with high-dose steroids, and then you give adjunct therapy, which can include cyclophosphamide or methotrexate. And due to possible narrowing of the renal vessels, it's important to monitor the patient's blood pressure and treat with antihypertensives, especially when the patient presents with hypertension. Now, the only definitive way to open up those stenotic areas is actually through surgery or angioplasty. Now let's do a board-style question. A 52-year-old female presents to the clinic with a left-sided headache accompanied by jaw pain. Physical examination reveals a tender left temporal artery. Optic examination is normal. Laboratory tests show an elevated ESR. She is diagnosed with giant cell arteritis. 2 weeks later, she comes back in due to sudden vision loss in her left eye. Vital signs are normal. Family history is unremarkable. She does not drink or smoke. What is the next best step in the management of this patient? A. Oral steroids. B. Intravenous steroids. C. Add cyclophosphamide to her regimen. Or D. Reassurance. Okay, this patient experienced a unilateral headache accompanied by jaw pain, and her age is greater than 50. There's tender temporal artery, as well as elevated ESR levels. And when you add those to those classic signs that she's presenting with, that's really indicative of giant cell arteritis. And today, she comes in with sudden vision loss in her left eye. Okay, so that makes answer choice B the correct answer. IV steroids are given to prevent vision loss in the uninvolved eye and to improve visual outcomes of the affected eye. So you want to go for IV steroids. Now, answer choice A is wrong because we're dealing with vision loss. IV steroids must be given to save her vision. The patient can be transitioned later to oral steroids, but oral steroids isn't where you start in these patients. Now, answer choice C is wrong because cyclophosphamide is not part of the management of giant cell arteritis. Answer choice D is wrong because this patient must be treated immediately. Reassurance without treatment would only allow her symptoms to worsen, and she could go blind. And this concludes our section on large vessel vasculitis.